Hi everybody, I am Dr. Arushi Choudhary. I am doing my PG in internal medicine from KIMS Bhubaneswar. I am back here to ask another question. A lot of my juniors, interns, colleagues have been asking me, and even me myself do not have much idea about this. There is a peculiar question they've been asking me. What should be the initial ventilator settings while ventilating a patient? So, sir, could you throw some light on it?
So, thank you, Aishu, for this question. And this question has been very much asked on our channel also. So whenever we ventilate a patient, so what should be the initial setting we should keep? So, obviously, whenever you go in the textbooks or manuals of critical care, there is whenever you study a ventilation chapter, there is a table in which they give you different settings for the initial ventilator settings, and these are good tables, and they give you an idea what should you start. But what we are going to do in some 10 to 15 minutes of today's video, that we'll try to understand the concept so that you will not forget whenever you are ventilating patient. You will have a better idea what those tables and what those settings are all about. So I would start in a way that we'll divide the patients in certain categories, so that in which category of the patient we should ventilate like that. So Ayushi, like, we need to ventilate and oxygenate the lung. So oxygenation, when we are talking about oxygenation, is about providing the oxygen, and when we are talking about the ventilation, we are talking about carbon dioxide. So we need to ventilate the lung. So we can divide the patient in certain categories. Like, one first condition is you have a normal lung. Your patient is having a normal lung. You are just ventilating or oxygenating for some different reason, like in Guillain-Barré syndrome or myasthenia, or patient becomes suddenly unconscious for XY reason, arrhythmia or some sort of. So there is no problem in the lung parenchyma or lung airway. There is no problem in the lung bronchus or like that, and no problem in the alveoli. So we are ventilating in normal lung. Then you have patients with COPD and asthma, where the problem is mainly of the airway. The parenchyma is sort of normal. So this is the second category. Thirdly, you have patient with a normal airway, but there is a problem in the parenchyma. It could be pneumonia, it could be basilateral electrolysis, it could be congestive heart failure. Like that, there is a problem in the lung alveoli, lung parenchyma. The severe form of this category is ARDS, which is a different sort of scenario where there is a very stiff lung and your alveoli are very much collapsed and you need to ventilate such patients. Now, this is just about the lung, like that. You also have a combination of certain things when you are ventilating patient. So you can have a patient with normal lung and patient is in trauma. So there is a patient is in shock or for some reason. So patient is in shock and you need to ventilate. The patient can be in severe metabolic acidosis. Patient is hyperventilating and then you need to ventilate. Then one more important category is patient is having some neurological insult, whether it's intracranial bleed or head injury or GTCS, something like that. So we'll try to find out the answers in dividing the patient in this category. So I hope you got this point.
Yes, sir.
So first we'll start with a normal lung.
individual.
So normal individual lung. So there is no problem with the lung parenchyma. There is no problem with the lung airway. Only thing you are ventilating because you just need to support the oxygenation and ventilation. Like in Guillain-Barré syndrome or myasthenia or motor neuron disease, there is a problem with the pump. So you need to understand and keep an eye on 6 parameters. You just need to keep an eye on 6 parameters while ventilating. So first will be your mode. Which mode? Second is your FiO2. Third is your, I would say, tidal volume or pressure. Fourth is your respiratory rate. Fifth is your PEEP. And the sixth is your I ratio. So these are the 6 parameters which will play a part in adjusting the ventilatory settings. So because we are discussing the initial ventilator setting, so I assume that all the patients in whom we are ventilating, we are giving sedation and neuromuscular blockers while ventilating the patients, and we have give sedation to the patients and we are starting the ventilation. So we'll assume that all patients whom which we have just intubated, they are in knockdown state with either some sedation or neuromuscular blockage.
Yes,
so the
sir.
first category. So in first category where there is a normal airway and normal lung, you just need to support the system. So how will you do that? First, obviously, the mode will be a control mode. It can be volume control mode or it can be
Pressure
control mode. Secondly, FiO2. So FiO2, because when you intubate a patient, there is a we don't know what is the safe apnea time. You have ventilated the patient. So for few minutes there is a depletion of the oxygen reserve. How much you have embowed the patient, how much you have pre-oxygenated the patient. So for few minutes, some 5 to 10 minutes, you keep the FiO2 on 100%.
Yes, sir.
So that whatever the lacunae has there or whatever time gap has been there during ventilating the patient, it can get covered up. Then after that, you need to target the FiO2 according to your PO2 level and SpO2 level.
So initially we have to be safe. We have to give the patient 100%
100% FiO2.
and then we'll titrate accordingly by seeing the PO2
and SpO2.
on the monitor.
You need to careful this in pediatrics, but we are not talking about pediatrics. We are talking about adult patients. So this is safe to give 100% FiO2 for few 5 to 10 minutes. Then you will target the FiO2 so that your PO2 in the ABG is above 80 and SpO2 is about 94%. So this should be your target. So you can adjust accordingly. Then the second, you have selected your mode, you have selected your FiO2. Then comes your tidal volume. So how much tidal volume? So because this is a normal lung, usually the books say that every patient now should be ventilated with lung productive ventilation, so 6 ml per kg weight. But 6 to 8 ml per kg body weight in a normal lung is fair enough. So for 60-70 kg patients, somewhere around 420 to 450 is a good tidal volume. You can multiply and then check. So tidal volume is somewhere like this.
Then minute ventilation is also there, sir.
So once you have decided the tidal volume, suppose 450 is the tidal. Now you need to, because we are just replicating our normal respiratory pattern in this with a normal lung. So respiratory rate will be 12 to 14, so that your minute ventilation is somewhere around 6 to 7 liters per minute. So 450 into 12, 450 into 14, somewhere like, so minute ventilation should be there. So this goes your respiratory, so mode, tidal volume, mode, FiO2, tidal volume, respiratory. Now two things left is, one is your PEEP and other is your I ratio. So PEEP, you should keep a physiological PEEP. It's somewhere around 0 to 5. So we usually keep somewhere around 3 to 5. There is no rocket science. You keep 3 to 5, whatever is feasible. Because what happens, so those who are listening, they should understand that what is normal physiological PEEP. What PEEP means is positive end expiratory pressure. So at the end of expiration, there is certain pressure which keeps the alveoli open up. It doesn't let the alveoli collapse. If there is no PEEP, alveoli will collapse. So there is a PEEP which doesn't allow the pressure to go beyond a certain limit. Yes. So can you tell what system keeps a physiological PEEP in a normal patient?
Sir, in normal patient, glottis keeps the alveoli.
Glottis is there. So suppose now I am not speaking. So this is the airway. This is the PEEP is maintained.
Yes, sir.
So whenever you talk, the PEEP is lost. When you are not talking, so this physiological PEEP is keeping. And when you ventilate the patient, intubate the patient, you go between the vocal cords, and then that physiological PEEP is lost. So for that matter, 3 to 5 is the PEEP value which you should keep
on the machine.
And then you have an I ratio. So I ratio, because the lung is normal. So in a normal patient, average breaths are 12 to 14 per minute. So if we keep 12, so 1 second for inspiration and 3 seconds for expiration. So it covers now your 60 seconds. So inspiration 1 second, expiration 3 seconds. So I ratio becomes 1:3. Some says 1:2, some says 1:3. So we keep 1:3. So in a normal patient with a normal lung, these are the settings: a control mode, FiO2 100%, then adjusting about according to the SpO2 and your PO2. Then you have a minute ventilation. So tidal volume and then into respiratory. Why minute ventilation is important? Because if minute ventilation is too high, like this, PCO2 will get washed out. If minute ventilation is too low, 4 liters, 5 liters, so ventilation is not taking place. So PCO2 will build up. So minute ventilation should be around 6 to 7 liters. So if you decrease the tidal volume, increase the respiratory. If you increase the tidal volume, then decrease the respiratory. So that minute ventilation should remain in the. Then you have physiological PEEP and then you have normal I ratio. Okay?
Yes, sir.
Now comes with second category of patient where there is a problem of the airway, asthma and COPD, sort of patients. Now, what is the challenge in these patients? 2-3 challenges. One is very obvious.
Hyperinflation of the lung is there, sir. So there will be air trapping.
Air trapping is one, but more than important that is the airway resistance. What is happening? One is air trapping, so lot of amount of air is there which is not getting exit because the lung is not pushing them out. Secondly, if at all the lung is getting out, there is a resistance from the airways. It is not allowing the air to get exit properly. So what is the problem is, there is no problem in the oxygenation. The problem is in the ventilation part. So we need more time for the PCO to get exit. So what setting adjustment you can do? Control mode is the same. FiO2 is the same. Tidal volume, you have respiratory rate, PEEP and I ratio which you can adjust. Obviously, we need to maintain minute ventilation, so we'll keep the tidal volume and respiratory rate accordingly. But important is here is I ratio, which is very, very important, and the respiratory rate. So in this particular set of patient, you need more time for the expiration. So you can increase the I ratio 1:3 to 1:4 to 1:5 to 1:6. Means if 1 second we are giving the time to exhale, you have 4, 5, 6 seconds for the exhalation. Exhalation. So we can increase the I ratio. I have seen many COPD patients, you have done everything right, but I ratio remains 1:1 somehow on the default setting or some like ventilator setting during ventilator shifting, and you feel that how this patient is retaining PCO2. So keep an eye on I ratio. It can be 1:4, 1:5, or in very severe patient 1:6. Secondly, what will happen in this? The air will go fast and it will slowly get exit. Secondly, if this is not helping you out, you can take help of the respiratory rate. If you decrease the respiratory rate, there will be more time for the air to come out. If you hyperventilate such patient in an effort to increase the PCO2 exhalation, but you are not allowing that through the I ratio, the air to get exhaled, it will cause increase in the PCO2. So you can decrease the respiratory rate, you can increase the I ratio, and if that is not helping out, you can play with the tidal volumes. So this is something. But in COPD patients and asthmatic patients, two things also you need to understand, that whenever you give positive pressure ventilation to the patient, so there is an increase in the thoracic pressure. Because of an increase in the thoracic pressure, the preload which is coming from the IVC and from the whole body and SVC, it gets decreased. So there is a hypotension. So make such patient pre-filled adequately, make them euvolemic, give some fluid bolus. Also, you have given certain drugs which can cause hypotension. So you can give some certain amount of fluid boluses during ventilation. Secondly, if your I ratio settings or if your respiratory rate settings, if this is not correct, it is very high, what will happen? The alveoli air trapping is already there. The alveoli if the alveoli get hyperextended, they will get crushed. So what will happen? It will cause dynamic hyperinflation, and this will again crush the capillaries in alveolar capillaries, and there is a drastic fall and a hypotension. How can you check that? Simple rule: disconnect the ventilator for a few seconds, and you will see BP starts coming up very fast. So this way you can check it. Now a word of caution on PEEP. What should be the PEEP? So this is tricky in airway disease patients. Usually we don't want the PEEP to be high in such patient because we don't want at the end of expiration, we don't want a pressure high. We want the air to get released. But there is a condition in airway where there is airway becomes fragile. What happens during expiration? If the patient is hyperactive, it's not properly sedated, it also tries to get active expiration. So intrathoracic pressure causes the airway to collapse. Already there is a narrowed airway. During expiration, there is resistance, and if the patient hyperventilate, this is when patient is hyperactive on the ventilator, then this intrathoracic pressure buildup causes the airway to collapse. So for those collapsed airway to remain open, we need to increase the PEEP. So that they don't get collapse. So whenever a patient, such patient who is hyper alert on this COPD patients, and you are feeling that he's not able to, you are not able to oxygenate the patient. It's not about ventilation. You are not able to oxygenate the patient, and this is creating a problem. So
in later stages of COPD.
Later stages, it's an advanced stage of COPD. You can increase a little bit of PEEP and check whether it is helping you out. So this is just the concept you need to remember. Now I think we have covered normal lung, then airway, and now the problem. There's a third category of the ventilation in which there is a problem in the parenchyma. So it could be mild, moderate, sort of like CCF is there, basal atelectasis is there, there is patchy pneumonias are there. So here we are not worried about CO2 problem. We are worried about we need to oxygenate the patient. We need to keep the PO2 high. So how will you do that? Obviously, mode will remain the same. Then you have FiO2 obviously is a temporary measure we can increase. Minute ventilation has to be in the range of which is normal required 6 to 7 liters. So tidal volume will remain same. Now, what you have with you, I ratio, PEEP and respiratory rate. Now, in this PEEP, we can increase slightly, like in CCF or like that. There is a fluid is there. There is consolidation is there. We need to give a little bit. You need to expand the alveoli, so we can increase PEEP up to 5, 6, 7, not more than that. Why not more than that? Because these are patchy diseases. Na? In normal alveoli will get compromised. They can get ruptured. So somewhere we need to increase the PEEP up to 8. We can increase. Some can go safely up to 10, but 8 is a safe limit. Now, if that doesn't help, we can increase the respiratory rate a little bit high, from 14 to 16 to 18 to 20. We can keep it a little bit high. Then you can play with I ratio. So here, what is the problem? We need to make the oxygenation better. So we'll increase the inspiratory time. So you are ventilating a patient on 1:3. Now you can go to 1:2. 1:1 is very extreme. We'll discuss in ARDS, but up to go to 1:2. But that's the principle. Now you are allowing more time for inspiration and less time for expiration. Now the same continuation of this parenchymal disease is extreme is ARDS, where there is very much PO2. We are not able to oxygenate the patient. So now we need to go to take extreme steps. So first thing is obviously mode. Mode we prefer pressure control mode in this because we have a safety limit in it. So we know how much pressure we are giving. Otherwise, it will again lead to volume trauma, pressure trauma, like that, barotrauma. So pressure control mode, which I personally prefer in ARDS, and some books also say that intensivists are more comfortable with pressure control because you know at what pressure you are giving the breath to the patient. FiO2 obviously 100 according to FiO2. Then comes your tidal volume. So every study, every guideline has told that in lung protective ventilation, 4 to 6 ml per kg body weight you need to give the tidal volume. So tidal volume we need to keep low. And then because you need to maintain minute ventilation, what you will do? Respiratory rate will be high. Up to 35 you can go. That's the limit. So up to 35 you can go to respiratory rate. In ARDS. Secondly, if these are not helping you out, see on low tidal volume and high respiratory, if you are not able to oxygenate, then on I ratio what you need to give more time to the patient for inspiration. So what you will do is you will come to 1:1 ratio, from 1:3 to 1:2, 1:1. And when you go beyond that, you have increased the inspiratory time to 1.2 seconds and 0.8 is the expiratory time. So you have reversed the ratio.
Reverse.
Means in normal patient, inspiratory time is less and expiratory time is high. But now you are giving inspiratory time more than the expiratory time. That's why it is called inverse ratio ventilation. So I ratio will be reversed, or it get to 1:1 or 1:2 like that. Then PEEP. So once you have oxygenated the patient, once you have opened up the alveoli, you don't want the alveoli to get collapsed. So you increase the PEEP. You give more positive pressure up to 8, 10, 12, up to 24 people have given. So in ARDS, it's a whole different lecture, but you understand the concept. Low tidal pressure control mode, low tidal volume, high respiratory rate, high ratio 1:1, or can we reverse and then high PEEP. So these are the initial setting. Ultimately, our goal is to maintain the oxygenation and ventilation. Now, what will happen, because we are giving low tidal volume and respiratory rate, there is a limit of 35 mils, and you have an I ratio in which you are not allowing the PCO2 to get out, means exhalation is you are not allowing. So what will happen? The PCO2 will rise in such patient.
Yes, sir.
PCO2 will rise. So, but the problem is your body tolerates hypercarbia better as compared to hypoxia. So hypoxia is not well tolerated, but PCO2 will get tolerated. So you allow PCO2 to rise beyond a certain level or up to a certain level, which is called as permissive hypercarbia, which is written in advance. Up to how much permissive? Till your pH, because of the PCO, drops to 7.15. And beyond that, you can use soda bicarbonate, which is written in the guidelines. So this is the concept of permissive hypercarbia. So this completes the patient who has only lung pathology, normal lung with airway disease, with parenchymal disease in moderate categories, mild, moderate, and then you have severe category, which you have ARDS. Now, we were discussing before this video very crucial points, that the patient usually in intensive care, or whenever they get admitted, they come up with a combination things like, so suppose a patient is in shock, whether it's a normal lung, airway, or whatever. Patient is in shock, patient is not able to maintain the blood pressure. So, and now you are providing a positive pressure ventilation to the patient. So you need to make sure that the BP doesn't get crashed after ventilating. So you need to first make sure the patient is pre-filled, patient is euvolemic, and give boluses to the patient, what if possible. If that's not the case, you need to take a little amount of vasopressors like NORAD support. So if the pressure is on 60, 70s, blood pressure systolic, you give the fluid. If that is not making the PP, take the patient noradrenaline, because whatever you do, 10 to 20 mm of Hg blood pressure will be dropped. So even if it is 100, you take a noradrenaline support of 2 to 3 ml per kg, so that 2 to 3 ml per hour, so that your blood pressure is in the safe range. So take precaution in that. You give fluid boluses, make the patient euvolemic, and then take if the support of vasopressors. Now, there is one more scenario, like if the patient has severe metabolic acidosis and the patient is hyperventilate like that, and you know you are going to ventilate. Now what happens, that patient is having severe metabolic acidosis, whether high iron or normal iron, that's a different thing, but because of
try to compensate.
Body is trying. So if the patient is having severe metabolic acidosis, so pH will drop. In that compensation, the PCO2, patient hyperventilate and exhale PCO2, so your pH bring back to 7.3 or 7.2.5, like that. Body tries to do that. So PCO2 gets low and it compensates the pH. But when you ventilate the patient, so metabolic acidosis is there itself. There's no change in it. But what you will do for that patient, if you keep the respiratory setting as if a normal patient like 12, 14, 16, PCO2 will come somewhere around 35 to 40. So because PCO2 compensation is left, is now abolished, your pH will drop drastically. So this patient can crash because of the very low pH like 6.9 or 7. So in a severe metabolic acidosis, whenever you are ventilating the patient for few hours, at least for 30 minutes, 60 minutes or 1 hour, keep the respiratory rate a little high. See how much the patient was. If the patient was ventilating, having a respiratory rate of somewhere around 30, 35, like 40, at least keep somewhere around 24, 26, like that, so that your PCO2 compensation is maintained and you will get time to correct the metabolic acidosis. And then After that, you can adjust. But don't keep the respiratory rate normal when you are ventilating a patient with severe metabolic acidosis. Anything left? One more important category, neurological patients. So you are ventilating a patient who has got a neurological problem, like there is intracranial bleed or stroke, or there is a head injury where there is chances of raised intracranial pressure. So in these patients, we don't want the ICP to increase. So what are the things we need to maintain? Firstly, whenever you ventilate this patient, make sure the patient doesn't get cough. Knock down completely and then ventilate. As soon as the patient coughs, there is a rise in the ICP. So many must of you experience that whenever you having headache and you cough or talk too much, you get the headache worse. You need to calm down. So make the patient properly sedated and knocked down. Secondly, your PCO2 targets should be somewhere around, so that your PCO2 is maintained somewhere around 32 to 35, 32 to 34, because PCO2 is a vasodilator. If the PCO2 gets very high, it will vasodilate and increase the edema. If suppose a normal PCO2 of 40, 45 will cause raised ICP because it gets vasodilated. Now if the PCO2 is very low, why not we decrease to 24, 35? It will vasoconstrict and it will increase the infarct. Ischemia, it can cause ischemia. So we need to keep a target of somewhere around 30 to 34 in a neuro patient. You need to adjust minute ventilation like that. Thirdly, you don't have the liberty to increase the PEEP beyond a certain level. Try to keep PEEP minimum below 5, because the more the PEEP, the more chances of raised ICP. So suppose a COPD patient has a trauma, has a chest injury, contusion, and had a head injury. So a combination of all. So you cannot give a straightforward guideline so that these are the ventilatory setting you need to maintain in such a patient. No, you need to decide the priority. COPD is there, parenchymal contusion is there, and raised ICP. Obviously, so priorities of the pain. So you may need to maintain the minute ventilation so that your PCO2 is 32, somewhere around 32. You need to maintain the oxygenation so that your PO2 SPO2 is about 94% and PO2 is around 80, above 80. Then you maintain the volume status. Then you try to keep the PEEP whatever minimal is there, like that. So one more category is there, but like pneumothorax. This is also one condition in which there is sudden pneumothorax and you are not able to getting time to decompress it, and the patient cries, you need to ventilate. So this is a tricky situation. So what is happening? There is a leak, and this leak is causing the air to get trapped in the pleura, and it has no time to get exhale out. Means you need to move out from the body till you put an ICD or needle thoracostom. So understand the principle. What we want, we just want the oxygen and ventilation to sustain the life of the patient. We don't want to hyperventilate. We just want to give some time so that we ventilate, and then by the time we put an ICD or something like that. So what are the scenario? Already the intrathoracic pressure is high. So already preload is low. So give a lot of fluids to this patient. Take the patient on vasopressor support. Then when you are ventilating, keep the respiratory rate a little low. We don't want the air to get pushed too much, even like that. Then keep the PEEP 0. We don't want the LY to get extended like that. Like that. Hai na? So I ratio 1:3, 1:4, like that. We don't want too much pressure for the inspiration. We don't want anything with pressure. So in pneumothorax, in such scenario, we want just to give oxygenate the patient, just to ventilate the patient, so that it passes that acute phase of somewhere 15-20 minutes by the time we put an ICD or something. So we need to give minimum support. We need to give minimum tidal volume, whatever we can. We need to give minimal respiratory rate, whatever we can. We will keep the PEEP 0 like that. We will give fluids to the patient. We'll take the patient vasopressor support. So like that. So these are the principles which you should understand. And now if you go back to that tables in your critical care book or medicine book or ICU manuals, you will find that these are the principles which are applied in those charts, and now we'll pick up very easily why this is going so or why this is going so. I'm very thankful for Arushi. Whenever she comes here, she have a very interesting question and which helps so many people. It was asked so many times on the channel, but I didn't get a time to make a video on this. Luckily, she came and she's always behind me that we need to make this, we need to make this. Very much
Yes,
thank
sir.
you.
This was very helpful, sir. I feel so blessed to be part of this video because it helps a lot. A lot of my friends and juniors have told me that it has helped them a lot. Very basic yet very to the point, and whatever we are encountering in day-to-day life, day-to-day practice, we are learning that only. So if you have still have doubt, you can just post in the comment section of this video, or you can go to ESBICM and then go to the forums and then post. Thank you once again, and again, do read more about it. Thank you.